What's OpenNotes? Just to make sure everybody has the context here, OpenNotes is a national movement dedicated to making transparency more obvious by encouraging clinicians to make their visit notes easily accessible. We are philanthropy funded. We're not a business organization that's selling a software or product, and we don't have a business relationship with OCHIN. We have loved working with them as partners in this movement around promoting transparency. Next slide. This is a simple idea. Oftentimes this gets too complicated because, as you'll hear, there's a lot of anxiety around this transparency. You know, I know some folks out there think, well, notes are for doctors, they're not for patients, and that argument's been settled. Patients clearly have the right to read their notes. All we're talking about is making making notes easier to get to. And you know, for that reason, I mean, this really is a simple idea. We're talking about efficient and improvement in communication. Next slide. Now, we know we've worked with 200 implementers and probably have another 150 out there who are in the process. I'd say 95% of them, the key concern they have is their clinicians are anxious. They are really anxious. They think that patients are going to be unhappy with notes. There's going to be increasing calls, lots of changes to requests to change notes. In the aggregate, that doesn't happen. There really is no evidence of significant increases in anxiety or complaints or lawsuits. Workflow doesn't change with one exception, and that's around documentation, and we can talk more about that. There is no evidence of increase in messages, calls, or longer visits. Folks will worry about the doctor-patient relationship, but there's no evidence that anything but good things happen to the doctor-patient relationship. And as you'll see, that's especially true in the patient populations that the safety net clinics serve. Trust increases. Even when there's an error, even when there's a concern, patients really respect their clinicians when those errors are sorted out, when their confusion is straightened out. Next slide. There's a key, I think, for this discussion. When you ask patients, including vulnerable patients, how do you feel about your doctor after you've read a note? 37% say they feel better. 62% no change. You add those two numbers, 99% feel the same or better about their doctor when they read a note. And this is especially true for older non-Caucasian patients with poorer health, lower formal education. So this really benefits the populations we're talking about today. You see the other numbers there that also, I think, provide some reassurance about what happens. Next slide. In conclusion, there's lots going on. Medicine and technology is changing. There's new rules recently out from Health and Human Services and ONC about the 21st Century Cures Act. We think OpenNotes helps to improve care and patient-centeredness with the minimal disruptions. We know there's concerns about those. They're genuine. They have to be managed, but we think they're manageable because based on our experience, implementation always ends well. In the future, we'll probably need to talk about getting better at implementation because, as you'll hear, it can be a little bit of a struggle for patients to figure out portals and find their notes. Next slide. So here's our panel, and with that, Sarah, why don't you kick this off for us?
Terrific. Can you hear me?
Yep.
Okay. Great. Thanks, John. So I'm Sarah Jackson. I'm the medical director for the Adult Medicine Clinic at Harborview. Next slide. And as you may not know, Harborview was one of the Oh, can you hear me?
Yeah.
At Harborview, we were lucky to be one of the first three sites to be involved in the OpenNotes original study that took place in 2009. Harborview is a trauma hospital, but our mission population is the most vulnerable patients in King County. and we have 5 primary care clinics there, including my clinic, the adult medicine clinic, in which we see patients with complex medical and social conditions, complicated mental health and substance use issues. And we also have an HIV clinic, and our downtown clinic, Pioneer Square Clinic, serves a homeless population. And we have an international clinic, which is all non-English speaking patients. And it was in the adult medicine clinic and the HIV clinic where the original OpenNotes study took place back in 2009. There were 42 primary care docs and 118 patients. Next slide. And before the study, we were interested in sort of checking in with our patients before the implementation of the intervention to see what they thought in the adult medicine clinic and the HIV clinic about this concept of being able to read their doctor's notes. And so we did 4 focus groups, and the themes that came out, the perceived benefits were really that they thought that by reading the notes, they'd be able to better understand their health and their disease. They thought it would be convenient for them, it would be empowering, and it would improve their relationship with their provider. They did, however, voice concerns reasonably about their privacy. This included HIV patients, worries about whether they'd be able to understand what was in the notes. They had concerns about whether this, using this computer would decrease their ability to have direct contact with their docs. And then very kindly, they were also hesitant about the potential time that it would take the docs if patients were reading their notes. And so John went over some of the original study findings. These I've just taken out and focused on the Harborview patients. So these are all our vulnerable safety net patients. And essentially, among the key outcomes, things like being more in control of their care, better understanding of their health and medical conditions, and doing better with their medications, they were in line with the other 2 sites, and that the vast majority felt like having access to their notes helped with these. They were rarely confused, worried, or offended by what they read in their notes. And the one thing that was significantly different at Harborview compared to Boston and in Pennsylvania was that 42%, or twice the proportion at the other sites, did share their notes with family or caregivers. And the vast majority, again, felt like this was something, after having used it for a year, that would be important for them in choosing a future doctor or a health plan. And then among the physicians for these vulnerable populations, they had, like other doctors in the study, a lot of concerns about whether this was going to really slow them down and cause problems for them. 0% reported that it took them longer at visits or in writing their notes, and just 11% said they were less candid in their documentation. And essentially all patients wanted to continue, and none of the docs wanted to withdraw after a year of this study. And then we were interested in looking more specifically at how these results played out. If you looked at the population of people, this is again from the original study data, of patients with HIV, and compared them to patients without HIV, and whether their perceptions of having access to the notes were different. And the short answer is they were not different. Patients with HIV were very similar to the other primary care patients about their risks and benefits. The one thing that was different, and again, this is in line with the Harborview population, was that they were more likely to share their notes. You can see 33%, 24%, 38% with friends, other health professionals, and doctors. So we think this is a good thing, that they are getting more support around their care from their other doctors for their chronic complex conditions, and from their support people. And interestingly, the HIV doctors, where this is a topic that you would think would be very sensitive, were actually less likely to change the candor of what they were writing in their notes compared to other primary care doctors. We also wanted to see what would for patients with mental health conditions. So specifically, we've looked at patients with diagnoses of depression, anxiety, stress disorders, including PTSD, bipolar and psychotic disorders, what their perceptions of having read their notes were compared to patients who did not have these diagnoses. And interestingly, these numbers are relatively small, but it's statistically significant. The patients with mental health disorders felt they did that they were better at taking their medications and remembered their plan of care better in higher proportions compared to those without. And then I think this makes sense too. They 8% compared to 5% after having read their notes did worry more. So that is something to keep in mind. And so that was 2009, 2010. In 2014, our UW system across all our hospitals opened the all outpatient notes system-wide, and we are on Epic. We, as a part of this, there were email messages from clinical leaders, there were presentations at department meetings, instruction meetings, etc. And I'd be happy to share our frequently asked questions that were developed for patients or providers if people are interested. There's also, I've attached some of the slides that we use for tips for providers about how to think about writing your notes when your patients are reading them, which are summarized in the, can you go back for just a second? Summarized in that Klein article, Your Patient is Now Reading Your Note. But I will point out that when UW opened everything, they did not actively market or message this to patients beyond trying to get them to sign up for the portal. Okay, next slide. And then again, this is a couple of years ago, we wanted to circle back again to our adult medicine clinic and HIV clinic populations. Now that they'd had years of access to notes to kind of get more qualitative information about how they felt about the notes. And so we did 4 focus groups again, including a little survey. We had them actually right before the focus group read through their last primary care doctor's note and then give us some specific feedback about that by survey. And they felt that 89% felt that the note content was useful. They did notice 20% essentially noticed some inaccuracies. And then about a quarter felt that there was too much medical jargon and that the templates were too long, which is, we have some pretty big templates in our, within the institution and clinic that I think that's true. Next slide. And then themes that they brought up was that when the content was confusing to them, they really relied upon their provider to explain it to them. And so they were using this as an opportunity to speak with their provider about their health conditions. They really liked having more compared to less detail in their notes. They really wanted to have all of their information. And then they did notice inaccuracies in the notes, particularly, as I mentioned, among the heavily templated notes. And then also of note, in each of the groups, there were 1 or more participants who were really almost evangelical about wanting to help the other members of the group or people with getting access to their own, if they weren't actively using the portal, helping them learn how to do it and showing them. Oh yeah, give me all the information because I'm going to look it up otherwise. So at least here it is. This is more bulk, more data. I think it's good. This is good information to have, and it would be good for my kids to know and have. I don't have to explain every detail to them. They would know what it is and how to go about it and take care of it. I think that's in fitting with the part about our patients sharing their notes with their support people. And then this is a sort of a continuation of this idea of trying to engage our patients using the electronic record. We're piloting, it's called the Our Notes pilot, where patients can, before they come into clinic, submit their interval histories via the portal, and then the doctor can add it to the note so that the patient gets sort of the first opportunity to put what they want to talk about. in front of the doc, and then the doc doesn't have to necessarily retype that into the note. We've been piloting that in our clinic in adult medicine and in another clinic similarly sized that has a more traditional insured population. And as you might expect, our preliminary data, the uptake is a lot greater in the traditionally insured population than our safety net clinic. So we've been, I think one of our big next steps is really trying to think about ways to support and assist our patients to sort of help bridge this gap, which I think is real. With either we've been using student volunteers or thinking about trying to get patient navigators to help our safety net patients. And this is just sort of a demonstration of across, this is just ECare active status. It doesn't mean that patients are actually actively using the portal, but at UW it's about 52%. In my clinic, adult medicine, it's about 32%. And you can see the HIV clinic is 45%. So these patients are really interested relatively to our other clinics in access to their information. Pioneer Square Clinic is the patient, serves the homeless population, and you can see that they are less likely to be enrolled in ECare. And then the non-English speaking clinic has essentially zero enrollment, but we do have proxy options for the portal, and that's not demonstrated here. Next slide. And then this is our really recent ECare dashboard, which for each clinic or the entity, you can kind of look and see what the enrollment is. And the part I wanted to just point out is the very bottom line, OpenNotes viewed. You can see that in my clinic, with about 1,500 visits a month, about 70 to 100 notes are being viewed by the portal. So it's a really small fraction. If you looked at this for the homeless population clinic, the Pioneer Square Clinic, it's about 5 to 10 notes that are being viewed. So just to summarize, after about a decade of sharing notes at Harborview, I think the big thing that people worry about is that this is going to be the end of everything for physicians, and really it has not been a burden for physicians, including our physicians at Harborview. That is not to say that I have not had individual patients, and I think if you talk to any doctor, there are patients who take issue or bristle at maybe how they're described in a note, so that does occur. Often they're patients who would have concerns about other things as part of their clinical care as well. And in my practice, I've had essentially 4 patients who I've had to make an amendment for or had discussions about notes over all this period of time. And then as I've demonstrated, the feedback about this has been very positive. I think we really think a lot about gaining trust for our vulnerable safety net populations, and sharing their health information and what you're writing about them electronically with them, I think is really, it shows that you trust them, and they appreciate that. It strengthens the provider relationships, and they really value having access to their own health information. And then as UW-wide, I just had checked in with folks just to see if there had been a big spike, or if there were a lot of increases in amendment requests. And there has been an increase since OpenNotes went live in 2014, but these are predominantly for inaccuracies. And I think we think of that as definitely a good thing. Segal Bell has done a lot of really good work looking at medical errors and using patients as partners to help us, cull out those random things that get into notes that are not correct. And so that's been our experience. And then I think really for our safety net patients, looking at ways to help support them and get them using this tool is one of our next pieces. And then, the next few slides I just included on in case anybody wanted to look at them. These are slides that we had used for our provider demonstrations before the go live, just with some very practical, patient-centered thoughts about what doctors need to think about in writing an open note that a patient is going to read. So like beforehand, using a template that's clear, and yeah. And then during it, there are lots of words that I think patients, there's a lot of concern that patients will see things like obesity or discussions about cancer. I think, the key piece is to really communicate directly so that, this is, if these are concerns, then the patient should be aware of them, and they should be things that you had talked with the patient about during the visit that are documented there. And then it is an opportunity to highlight the strengths of the patient. Yeah. Okay, I think that's, yeah. Yeah, you can use it for feedback later.
Okay, so thank you, Sarah. Anshu, can we bring up Anshu's notes? And you want to take it away?
Yes, I'm Anshu, and actually I trained in the adult medicine clinic with Sarah Jackson and was part of that first OpenNotes study, and then brought OpenNotes to the Los Angeles County Department of Health Services. Next slide, please. So when I came here back to Los Angeles, we did a QI survey of our patients in our medical records line and asked, why are you here, and how much time are you spending here, and what are you trying to get out of your visit today? And overwhelmingly, our patients were looking for their doctor's notes. And there were some things that they were looking for that they already had online through the patient portal, but we didn't have great uptake of the patient portal at that time. So labs were also a very popular thing that was available on the portal. And of course, there was interest in things like operative notes, discharge summaries, emergency room notes, imaging reports. And what we decided at that point in speaking with our patients is that we could release a lot of that online and make it easier for everyone. And we had patients sometimes waiting up to an hour in some of our busy hospitals waiting for their medical records. And they reported they were paying up to sometimes $300 based on the cost per page of printing, which was very restrictive. Next slide. And so we started a pitch for OpenNotes at DHS in LA County, and this is actually part of the presentation that we gave our provider groups, we gave in grand rounds, so you're seeing a little bit of that here. So we believed that it was the right thing to do for our patients, and we knew from the data that Sarah presented that patients feel more in control of their health and have increased trust with their providers just through the act of sharing. And we believe that it promotes patient-centered care and patient engagement in medical care. Next slide. And so we started sharing notes in January 2018, so it's been a little over a year now. And we did not release older notes, and this is also a little bit of the Cerner build because we are on Cerner. And we did have some issues with this initially, so our primary care docs were a bit concerned. So we delayed their rollout to April, but that gave them 3 months to kind of get comfortable with the initial rollout, which was pretty broad, and I'll talk about that. Next slide. And we decided to post notes 72 hours after the note was signed in the chart. This was specifically a concern around, we have a lot of training physicians in our hospital-based systems, and so attendings wanted the opportunity to addend a note. At this point, I think we might actually move this to immediate because it doesn't seem like it really has much effect. And patients in Cerner can see that a note is pending or a study is pending, and so sometimes that can cause a little bit of anxiety as they would like to see that right away. Next slide. So one question that a lot of people had was, is OpenNotes the same thing as an open chart? Is there everything in the chart, is that seen in OpenNotes? And our answer to that was no. The purpose of sharing notes was really for patients to better engage in their plan of care and to have key clinical notes that could help patients engage in that care. And we were already sharing our imaging notes at that point. Next slide. So we shared inpatient notes, so we shared history and physicals, discharge summaries, and specialty consultations. We have two types of specialty notes, consultation and progress notes. And we did not share the progress notes because we find those to be very wordy and sometimes inaccurate. We shared our emergency room, our ED provider notes, and our urgent care provider notes. And then outpatient, we shared all specialty clinic notes, and then in April, we shared all primary care clinic notes as well. Next slide. So again, these were some of the note types that we did share, and these were some of the things that came up as questions. Are we going to share HIV primary care notes? There were concerns with California law based on HIV results, but that is very different than chronic care. And then there were questions around pediatrics, which we'll address as well. Next slide. So we didn't share some notes, and you know, we wanted to share some of these notes, but we couldn't quite get in some of the buy-in for our behavioral health providers at the time, although we were going to be readdressing that in 2019 because we have some of our psychiatrists and social workers who are very interested, but we're going to let them lead that conversation. We plan for parents not to have access to adolescent notes. We do have forensic and foster care clinics for pediatrics, and those notes were not shared. We didn't share social work notes, and also some phone messages and clinic communication. I think you could kind of go both ways on that, but we had concerns about the sensitivity of that and sometimes the way that our staff would write in those notes. And then nursing notes, although we just started releasing care management notes last week, I think. Next slide. And so adolescents. So, you know, everyone, I think, handles adolescents differently. And I am not a pediatrician, and so we relied on our experts in pediatrics. We had some issues with Cerner around the privacy protections for adolescents, so we actually had to close our adolescent access because we couldn't mark certain visits as sensitive, like a family planning visit or an abortion procedure. But some of that is being fixed currently, and when that is appropriate, then we will relaunch our adolescent portal. And again, that affected parent proxies as well. So it's tough because we have to be careful about those appointment types, and there are certain California laws that we had to keep in mind, especially around adolescent care. Next slide. And then what if there's a note that you don't feel comfortable sharing with a provider? We ask our providers to use their clinical judgment. They're able to use the sensitive note type when writing that note. And we're trying, I loved the graph that Sarah showed on kind of the uptake. I would love to have something similar to that. How many notes are being seen, how many sensitive note types are being written. The way that we gather that right now is all kind of through Sentinel data collection. Is just a little more complicated than it needs to be. So I can't tell you how many sensitive note types have been written, but I know other health systems have good access to that. But it looks like it's being used pretty infrequently in our health system from what we've been able to capture. And we always remind our providers that still patients can go to medical records and they will get their entire, all of their notes. And so keep that in mind when you're writing your note. Next slide. And so this is what the patient can see. We labeled it clinician note, and then they're able to see all of their notes there. Next slide. And so these are some of the do's and don'ts, and I think for the sake of time, we'll go to some of the next slides so everyone can present. So these were some of the things that we mentioned to providers. The language, I want you to look at my notes and make sure we're on the same page. Reading your notes may remind you about what we discussed when you get home. So we have a provider who has some patients at one of our LA County clinics who feels like the level of engagement with his patients has really changed as they're reading their notes, that they're coming in with more high-level questions than the discussions they were having previously. So that was one anecdote I found interesting. Also things that Sarah has mentioned, like minimizing abbreviations and then sensitive topics. Next slide. We agree, patients do find errors in provider notes, and we have a policy in medical records for that, so we are continuing to follow that policy as it applies to OpenNotes. We have not had many patients correcting notes, but like we said, some patients have to wait an hour to go to medical records, and so you can imagine that we have some other barriers there. And then there's some additional examples. So around substance use, I think that's certainly a conversation that comes up in our medication-assisted therapy clinics, where patients may want a diagnosis removed. And really it's a discussion about that diagnosis and why that's important. And I was talking with one of our providers in that clinic. He said that he's never had that discussion escalate, just as a confirmation of this is why we're treating you here in this clinic and this is why this diagnosis is important for you. Next slide. And that's all I have for you.
Thanks, Anshu. You know, I can't resist. I have a neighbor who trained at LA County 40 years ago, and oh my gosh, what an incredible system, and really what an accomplishment that you've championed. Thank you so much. Jen, you're next up. Take it away.
Sure. Hi, everyone. My name is Jen Lau. I am a Senior Director of Primary Care Transformation within the Office of Population Health at New York City Health and Hospitals, and coincidentally, former President of LA County, Dr. Mitch Katz, is now the President at New York City Health and Hospitals, so fun to see all the connections between the presenters. Thanks so much for the opportunity to share some of our work. So this slide will outline some of the things I'm going to cover today. Next slide. Very briefly, a little bit about who we are. We are the largest public safety net system in the country. We serve over 1.2 million patients annually. We operate 11 hospital sites, 5 long-term care facilities, and over 70 outpatient clinics. We have school-based health clinics. We offer our home-based services, and we also have an affiliated insurance plan, Metro Plus. That's part of our system. Approximately 475,000 of our patients are uninsured, and we have certainly a diverse patient population, one of which is linguistically diverse, and you can see that, you know, there are about 190 languages spoken across the system. Next slide. Here is a snippet of some of the guiding principles and objectives for the Office of Population Health. We like to take a proactive approach to addressing avoidable human suffering, and the objectives of any intervention is we want to make sure that the patient and family are at the center of his or her care. We're meeting consumer needs and demands for care. We really want to emphasize care happens in the visit as well as between visits, so how can we enhance patients' abilities to self-manage, and also working with others to help him or her be healthy. And, all this to say that, OpenNotes is no different than this, and ultimately we look for interventions that are high impact, and help patients find care that's more accessible and convenient. Next slide. So I think, not surprisingly, OpenNotes is a pretty compelling initiative for us to take on. So we've decided to provide open access to patient charts via MyChart, which is the Epic patient portal. What you see on the screen are different icons that our patients have access to. The lower left is actually the icon for OpenNotes. Soon after we implemented, we actually decided to change the label on this, so it actually says read your doctor's notes. So we found that this was more immediately transparent to our patients, and they could better understand what this button was for. Next slide. So currently our OpenNotes exists in Epic MyChart, which not every facility in our hospital is on yet. I'll talk about that in a little bit. All our outpatient visit notes are shared by default in Epic. So at the outset, for every clinic that went live, we decided to go by default at the start. And we are also sharing resident notes, which, as you can see, are shared once co-signed by an attending. Currently, we do not yet share behavioral health notes for some of the similar reasons that you've heard our colleagues mention, but we want to revisit that discussion. For our pediatric patients, we are not sharing notes for those above the age of 10, and this is similar to LA County, not so much a OpenNotes reason, but a MyChart reason. We don't have a great way of segmenting access between patients and patient access from caregiver and parent access. So once we figure that out, we would like to actually share notes of our adolescent patients, but we haven't quite figured that part out yet. And our providers can decide to opt out of sharing individual notes on a case-by-case basis. Next slide. Here's a little bit more about our broader journey for OpenNotes. So before we started, we did some qualitative research to understand, what our patients are experiencing through on-site observations and informal interviews. Thanks to a grant from New York State Health Foundation, they actually helped us kick off at the first 3 EPIC sites, Queens, Elmhurst, and Coney Island hospitals. Since then, OpenNotes is now part of standard build, so once the site goes live on EPIC, OpenNotes is already enabled. I'm sure it's no surprise to folks and the experienced implementers on this phone call, but securing provider and senior leadership buy-in was incredibly important. So we had solicited support and received support from chief medical officers, CEOs. This took a lot of face time and virtual time at presenting and hearing concerns at directors' meetings and departmental meetings. Now, it's less about some of the technical things outside of the certain departments I mentioned earlier, but it's about understanding how are we going to influence both patient and provider behavior. And so we're looking to other disciplines and looking at behavioral science to see how we can do that. So for example, for providers, we know that defaults, people tend to go with the flow of a default. So it was really important for us for having OpenNotes be a default option for that reason. The emails that come out of EPIC are actually signed or sent via your care team. So it looks like the care team is communicating with the patient. In some of the videos we created to teach patients about OpenNotes, we frame the access to OpenNotes or access to the note as patient empowerment. And right now we are exploring how to actually test and quantify the efficacy of some of our efforts. So for example, we are trying to measure how effective it is to send out, say, an email in Spanish for Spanish-speaking patients about viewing their notes. We also have one RCT for providers to see whether or not sharing provider performance, so how often a provider shares his or her note relative to his or her peers, impacts patient view rate. So we're really trying to increase the rigor around some of the interventions we're doing to try and increase view rate. Next slide. Here is a visual representation of how we expanded OpenNotes. So you can see early in 2017, it was really only at the 3 EPIC sites. We actually first started with primary care and then expanded to specialties. Last year in 2018, we expanded to peds and then enabled resident note sharing. And this EPIC Go Live 3, so approximately October 2018, was the first time that OpenNotes was part of standard build. And you can see for the rest of 2019, we are rapidly racing to get the rest of the system all on EPIC and off of some of our legacy electronic medical record systems. So come 2020, there will be a lot more patients and a lot more practices on MyChart, which would be great. Next slide. So here is OpenNotes in a few numbers. This goes through March, so this is just before our Go Live 4. But you can see that there are 286 EPIC departments that are currently participating. This roughly translates to about 1,500 providers that are sharing their notes. Over 905,390 notes have been shared, and our view rate among MyChart patients is about 9.1%. So, OpenNotes is slow and steady. I think one of the early concerns from providers is that all my patients are going to start opening their note and they're all going to start asking me questions. I think OpenNotes is a complicated process, not just OpenNotes, it's MyChart. It's education and training, and it's totally worth it. And right now, much of our effort is less on OpenNotes per se, but just on broader awareness and adoption of MyChart. In 2018, can you go back? Thanks. We also wanted to make sure that we asked our patients what they thought, so we conducted a survey, and one of the questions that we asked our patients is, how strongly would you recommend OpenNotes to friends and family? And so that's what we mean when we say the Net Promoter Score, which is a nice proxy for customer satisfaction. And you can see there's a score of just over 77%. For context, if you're thinking about companies that actually have relatively high customer satisfaction, Net Promoter Scores typically range in the 75 to 80%. So this is pretty high compared to that standard. So for patients and families who have access to OpenNotes, they would highly recommend it to someone else. And when we asked our providers what they thought about OpenNotes, you can see that, it echoes some of what my colleagues have said, that providers after the fact reported that there was little to no impact on both their workflow and workload. Next slide. I'm not going to read all these quotes to you, but here's a sampling of some of the comments that our patients shared in their survey. Again, it echoes positive experiences with OpenNotes and echoes some of the previous research referenced. Our patients mentioned that they had improved patient-provider relationship. It increased trust between him and herself and their physician. They felt that they had a better understanding of their medical condition, were better able to follow their care plan. And you can see this last quote, they were actually hungry for more information. Next slide. Just some quick quotes from our providers. Again, all in all, positive interactions, and again, little to no impact on their workflow or workload, and we're very appreciative of actually some of the conversations that they had, and we're impressed, perhaps by surprised, I think might be a better word, by how empowered some of their patients felt after the fact. Next slide. So, no initiative is not without challenges. So for us, as I mentioned earlier, patient portal uptake is still relatively low. We're focusing a lot on enrollment and actually ramping up broader functionality across MyChart in our patient portal, which leads me to my second bullet. Earlier this year, not everyone in our health system had access to Epic, which means they did not and could not participate in OpenNotes. So that's rapidly changing. I think some of my colleagues who have Epic know that just getting to OpenNotes can be challenging just within MyChart. So I think through successful lobbying and partnership with other Epic organizations are working with Epic to make it a little easier and more obvious to find visit notes, both on a web-based version as well as on the app. And you saw 190 languages are spoken in our system. The EHR is only available in one language right now, English, so we do a lot of support sort of outside to help meet some of the language needs of our patients, but unfortunately it's not an inherent function yet. In addition, some of our challenges are just, resourcing within our system. So much of our IT resources are currently focused on Epic implementation and getting all sites up and running, which means fewer resources for us for MyChart optimization or even just OpenNotes optimization. And, you've heard it in some of the previous presentations, there is always hesitation and anxiety among providers who are just getting used to this concept, but eventually those concerns are unrealized. And I think for those who are considering launching OpenNotes, just anticipating that and just providing a lot of resources up front to manage that and communicate and educate. Next slide. So here are some of our next steps. Our biggest thing, again, is continuing the system-wide implementation of Epic. We've actually bulked up some of our provider education, so it's the third sub-bullet. In providers' clinical documentation training before they go live on Epic, there are a couple slides or components focused on OpenNotes. In addition, we have an OpenNotes-specific e-learning module, which is an interactive online module where providers can actually go through a couple scenarios. about OpenNotes, whether or not they should share, and actually providers interact with the module by clicking in order to actually advance through the training. In addition, we're continuing to augment MyChart overall, so we're not just championing OpenNotes, but just this idea of an electronic front door, that there's a new way of actually engaging with the care team and the healthcare system at large. We do want to revisit the discussion about sharing mental health notes. We do have quite a few number of collab care clinics, so integrated primary care and behavioral health clinics, who would be interested in sharing behavioral health notes. So we're going to revisit that conversation with those at the lead to lead that conversation. And, starting to think through some additional metrics. You've heard me talk a little bit earlier about some of the RCTs we're trying to run. Some of the other metrics that we capture are pretty specific and granular to really try and understand the root cause of different utilization patterns that we see. So, for example, we measure number of notes signed, number of notes shared, how many of those notes were then pushed to patients who were then offered MyChart, who then actually signed up for MyChart, and then what was the view rate on that. And similarly for patients, we take a patient view as well. How many patients have encounters with signed notes? How many of those patients also have MyChart? And then how many of those actually view their note? So really trying to develop the metrics to help measure the impact of some of our interventions as well as just adoption overall. Next slide. So this is my last slide, just some reflections for the group to consider. Communicate, communicate, communicate. It was really important for us to engage both providers and staff very early and adopt a tailored approach if necessary, whether that's always in-person meetings for one group, always presenting at every single meeting if necessary. We were there for our teams to really understand the importance of OpenNotes. I think that then translated to really strong sponsorship from clinical teams, and it was so important for us that the clinical leads were messaging this and promoting this as opposed to IT. We knew that would be, a dead end if, IT was here marketing this. It was about making an impact on patient care and our patients, so that's why it had to come from our clinical teams and our clinical leads. And, those are the biggest champions. It's not from us in the presentations, but it's really about the messaging day-to-day not when the OpenNotes program team, but it's really the day-to-day conversations with clinicians in the clinic about how this could help them in their day-to-day. And coincidentally, we found that just the idea of mentioning that patients might read the note subtly changed how doctors sort of viewed their notes and even started documenting. So it was pretty remarkable to see just the idea of OpenNotes, even before we formally turned it on. Folks anecdotally said that it changed how they documented. I think the other thing, which was really important, again, defaults. I don't think this could have happened if we didn't do OpenNotes by default. I know other organizations have considered sort of a slow approach and incorporating default note sharing later, but for us that was important, and I don't think it would have happened otherwise. The other thing that I think was really important for us is that OpenNotes is just one of so many ways to engage patients, and for us it was about providing options to patients to engage with their care, and it's not about having patients engage and participate in every single option. It's just finding the option that works best for him or herself. So even if only 10% of our patients access their notes, that's 120,000 patients. That's great. And so one of the other things that I oversee as part of my team is broader telehealth. So OpenNotes is one piece of MyChart, which is one piece of the broader sort of digital toolbox that we like to call at health and hospitals. We're exploring text-based communication, care delivery, video visits, et cetera. So it's really helpful to sort of think about what else is OpenNotes a part of. I think the other thing that was really surprising for us and important for us to remember is that our patients are ready, and it's really easy to buy into anecdotes that we've been telling ourselves. Our patients are either too poor or they're not tech savvy enough. and they won't understand. So it's really easy to underestimate our patients because maybe they don't speak English as a first language. But I think, buying into those anecdotes really reinforces, inequity, and particularly inequity to access to technology that could be really great to enhancing the care that they receive, because we know our patients, they want convenience, they want more time back in their lives. And, for some of the language barriers, others mentioned this proxy access was really great to help engage other members of either their family or caregivers who do and can understand English to help bridge some of these language barriers. And our patients know what they need. They're pretty savvy. Even in New York City, which is a fairly diverse city, our patients are used to navigating a predominantly English-speaking world. So I don't think we give our patients enough credit for their capacity to navigate and problem solve. And last point, measurement of performance is important, both from the implementation phase, but as well as both measuring and patient satisfaction, and just knowing troubleshooting, knowing where you need to port your resources. So that's it from me, and I'll stop there.
Thanks, Jan. I know we're close to the hour. I would like Andrea to go ahead and present. And any of you, we understand if you need to be on to other commitments. I know I'll stick around when Andrea's done, and I think other OpenNotes folks will to answer any questions. I assume, Amanda, that that's all okay with the system here?
Yes.
So, Andrea, go ahead. This has been incredible information. Thanks to all of our speakers. Andrea, go ahead.
Thanks, John. And I'll try to make it as brief as possible. I'm more of a bullet point presenter anyway. But this is Andrea Strecker. I was the project manager and one of the co-leads on the implementation of OpenNotes at Rochester Regional Health. We're one of the 2 largest health systems in upstate New York, and we actually did a joint launch with our competitor, which I'll talk about a little bit more. Next slide. So this is just our mission about our health system, and the left hand visual on the slide just shows what area we cover in Western New York. Next slide. Our health system has 5 hospitals, over 16,000 employees, over 2,500 medical and dental staff. Then just another couple key statistics about our health system. Next slide. And this is more specific to the group that we launched OpenNotes with. So our Primary Care and Ambulatory Specialty Institute was the group that actually took on the grant for OpenNotes and was the one that wanted to move forward with piloting this project. So we have over 87 locations. We have over 30 federally qualified health centers, which make up the majority of our Primary Care Institute. We have 10 integrated sites, so 10 of our sites have therapists integrated into them where providers can refer to those therapists physically in the site, and over 450,000 patients and over 300 medical providers. Next slide. Just a little bit more detail on the services that are provided within the health centers. And then I believe the 89,000 was from the Uniform Data System from 2018, how many patients we served within those health centers. Next slide. So our journey to OpenNotes actually started a few years ago. We had 2 different sites that were more urban that wanted to pilot OpenNotes. They actually launched between 4 providers, the default sharing where they shared all notes for a few years, and then not much happened within the system until the New York State Health Foundation sent out a request for proposal for New York hospitals and health systems to apply for the grant. Our competitor, the University of Rochester Medical Center, and I both had key leaders that attended that session where they determined if we were both going to apply for the grant, we had to do it jointly together, and that would be the best for the community. So we basically worked weekly side by side with U of R from the end of August 2017 to the beginning of this year, and we still talk with them pretty often. But we had a huge planning team, both within our systems and jointly with them until our launch. And I'll talk a little bit more about the specifics at RRH, what happened as time led up to our launch. Next slide. So just this briefly describes in more detail what happened from the timeline. What led up to the pre-launch planning is when we kicked off our internal and external planning teams, the guidance from leadership was to go around to each of the primary care sites to have the discussion about how the providers felt about launching OpenNotes. And so we went to 80 plus practices, had the conversation, shared the OpenNotes PowerPoint presentation, and what we got is that 80% of providers were okay with the concept and 10% were completely against. They were going to quit if we did this. And so we had always thought for the 4 months we were going around having this discussion, we were going to go automatic default sharing and share every single one of the notes. And about 4 months before we planned to launch OpenNotes, our leadership team decided to change the strategy and go opt-in. And because of the agreement we had made with the University of Rochester and the joint PR launch we were planning on doing together, they didn't feel comfortable with the two different strategies. So we had agreed upon, even if we were going to do the opt-in mode where each of the providers, can share notes on an individual basis or change their settings to share all their notes, we would want to get to a point where at least half of our providers were sharing all of their notes, so we could say to the community that the majority of our providers within both health systems are launching OpenNotes, and we're doing this for the community. So in September of last year, we launched the opt-in version of OpenNotes for all of our primary care and ambulatory specialty institute. And then again, my co-lead and I went on a 3-month-long roadshow where relationships and conversations with providers allowed us by the end of December to hit over half of our providers changing their settings individually to share all notes, which is a true accomplishment and something I would not recommend because just the amount of work and time that went into that, and the lack of response or any issues after the launch really sort of shadow that it's not that big of a deal. Next slide. So what we did in preparation for the launch, we put together a really extensive toolkit, which I'd be happy to share with our training education team. We met with our health informatics group to make sure that we had processes in place if all the concerns the providers were bringing up actually came to light, which they didn't, working with the IT team. And I think one thing that we did was really great, and I think it can happen before or after launch, but our training and education lead provider did e-huddles where practice managers and providers during lunch for 15 minutes could log into a link or Skype meeting and sort of see what the functionality actually looks like and how to make changes within their settings. Next slide. Okay, so this I sort of briefly touched on, but our two leaders met in New York to talk about doing a community-wide launch, really helped that we were transparent with each other with the challenges we were each facing within our systems. And then we really used actually us being competitors to help within our systems, sort of the pushback we were each getting to get us to a place where we could meet our numbers, and the U of R could also be ready for their launch. And they launched in January, the default mode for all of their outpatient groups. So obviously I sort of pointed at this changing mid-course and sort of the strategy of the launch didn't really work. The amount of time and effort that went into that is difficult. So I hope at some point our system gets to a place where everything's default because there's still a push and not all providers are sharing all of their notes. So next slide. So our overall results, as of last month, 57% of our providers are default sharing, and then just sort of highlighting 6% are against or just refuse to share. Next slide. And then just want to show here that we actually had better buy-in with our FQHC providers. The feedback that we got for the majority of them was just any way to engage their patients is a benefit, and they were okay with sharing. Next slide. So how did we communicate with our provider network? We did tons of emails. We shared metrics with them once they had the option. If you're not sharing, if you're sharing some, or if you change your settings, we thank them. A little bit of peer pressure. My co-lead had actually been a provider within the FQHCs for 20 plus years. So the relationships he had built really helped us to get people to just do it, just anxiety around the culture change in that. And then again, the competition, our competitor was going to do this regardless. So 50% or more of the people in the Rochester community were going to have this sort of access. And if we didn't do this, what would that mean for our health system? And then, of course, we rewarded our practices when they got all of their providers to change their settings. Next slide. So I just want to highlight real quick, because I know we're over. Everyone will hear this. We are different. Our providers, every single practice we went to, we're different. We see different patients. After OpenNotes launched, we didn't hear anything from the providers. So a lot of fear and anxiety, but once it happens, it's okay. Next slide. Just wanted to share a couple of the joint materials that we did with U of R for PR purposes. The left-hand side was an ad in the Rochester Business Journal. The right-hand side was an article in our Democrat and Chronicle. Next slide. And then just a couple of the changes we made within our MyChart patient portal. The university made these changes as well, but just made sure we wanted to highlight where the patients could find the notes. Also on the second picture on the right, you'll see Search for Medical Library. That actually opens a link to Medline Plus. A lot of the providers, same concerns about patients not understanding medical jargon. Well, there's a link right there. If they want to copy paste a word they don't understand, there's a medical library for them. Next slide. And I think that's it for me. Thanks, everyone. Sorry for going over.
Oh, Andrea, that's terrific. Thanks so much. As I was saying in the chat, I really wanted you to present your experience, because no one's been more successful at an opt-in than you all have, and especially, you know, the decision your executives have made with hardly any time left in your timeline. You all are just terrific, but it shows you have to get out there and you have to really convince folks. I mean, anxiety is hard to overcome, and you all have just done a terrific job of it. So I know we're beyond the hour. I know Anshu has had to leave, but those of us who can stay are happy to respond to any questions. Andrea, we would really love to get your toolkit, so if you could send me a copy, I'll send it to Melinda Fulmer at OCHIN, and we'll send that toolkit out, okay?
Yep, I'd be happy to. Thanks.
All right. Any questions? I see one issue in the chat that comes up, and that's timeline. You know, we have a lot of experience with the timelines for doing this. And it also kind of depends on your perspective on timeline. At the annual meeting for OCHIN last week, I reminded folks that actually OpenNotes has been talking to the OCHIN organizations for 5 years. And we've made multiple presentations. We've offered small grants. I think many of you all have had the opt-in. and with one click, folks could have shared buttons. And I realize that the decision the OCHIN board made in the fall, seems like, one that, you have to get going to work around this anxiety. But I think you've also heard the advantages of the default approach. I think you can see that I loved, I think, Jen's comment that at New York City Health and Hospitals, this was slow and steady. So the default to opt-out doesn't mean this is going to be a tsunami. It doesn't. This is going to be slow and steady with lots of decisions for each organization to be made. You notice that I think I'm forgetting now. Oh, UW did not tell their patients. They didn't promote this to their patients. And you all are going to have to decide, each of you, to what degree are you going to promote this and encourage patients. So you still do have a lot. I understand the anxiety, though, and if anyone wants to make any comments or about that, step up here, please feel free.
So this is Andrea Strecker again with Rochester Regional Health, and just to echo what John said, so our competitor, the U of R, actually did go opt-in a year before changing their settings to default, and they didn't put as much resources and time into getting people to try changing their settings, but they did communicate about sharing notes, and the amount of notes shared from opt-in versus going default was a complete 180, and default's really the way to go.
Hi, and this is Melinda Fulmer from OCHIN. I'm not sure how many OCHIN members on the webinar today were able to attend Learning Forum, which was last week. This is OCHIN's annual conference, but we also had a member panel which consisted of OCHIN members who were early adopters or who piloted shared notes. And the one thing I can tell you is, out of all these groups, they were able to accomplish in the same time frame with their pilots going live by default, the same time frame that we have here for the entire collaborative. And one of the things that all of the presenters, we had Monterey, Winding Waters, and Bastyr University, they all said that, by sharing it by default, some clinicians indicated, well, I will just unclick to exclude a note. But as they saw all their colleagues around them sharing notes, hearing the benefits, and not experiencing any problems, that convinced those who were sort of against the idea of sharing notes that this is the way to go. So again, we have experience within OCHIN, within members with the same patient population that you have, that have had great success with that.
Thank you, Melinda. Others? Any others? Is that somebody wanting to ask a question? Okay. Well, let me wrap up. This is all recorded. Amanda will get to work on this, and we'll be emailing everybody who was registered for the conference with a link to the presentation. You will be able to just listen to Anshu in LA County, or just to Sarah, or just to Andrea, or just to Jen, or listen to them all. So the recording, is really great in that respect. OpenNotes is very interested in doing anything with any of you to help this process along. You can email me, santa1177@comcast.net. Go to the website and communicate to us, opennotes.org. Obviously, OCHIN staff know how to reach us, and and are there to help. I know that our executive director, Kate DeRoche, is giving a talk next week at the Boston Healthcare for the Homeless. I was intrigued when I saw Sarah Jackson's slide because I actually didn't know that they had a clinic, the Pioneer Clinic, which she mentioned, which focuses on the homeless. As you know, she mentioned the uptake there of reading notes has been slow, but there's an organization who's focusing on the homeless, and we really should hook up UW Pioneer Clinic and Boston Healthcare for the Homeless. So lots of opportunities out there. We would love to help, and unless anybody wants to say anything else, we're done. Thank you all so much, and thanks for hanging in there with us.
And John, on behalf of OCHIN Collaborative, we really appreciate the time. And to all the presenters, thank you so much for sharing your initiatives. Again, thank you all so much for your support.
Thank you.
Thank you all.
Bye-bye.
Bye.
Thanks, everybody.